Thank you all for coming, though. But my first thanks will go to Dr. Elaine, for setting this up for me to be able to present this to you guys. And second thanks will go to Dr. Rose, for being the technical lady here and there, doing the recordings for me. And I also thank you all for coming here for the presentation. All right. My name is, you guys know me already, and my name is Seth Owusu. I'm a PharmD candidate at the University of Colorado School of Pharmacy. And my topic today will be the role of dexmedetomidine in the sedation of ICU patients. I'm going to be interchanging the word dexmedetomidine and dex, since it's too long to be pronouncing. And if you hear me saying Prexides, it's also the same thing. So you can start now. Next slide. As you can see, this is like a typical ICU room that you're looking at, and you can see all these hooked up wires, cables, tubings, electronic devices, and so many things, including this guy, which is like one of our IV bags. And you're expecting the patient to be lying around here, surrounded by all these instruments. And for this reason, this is really like a typical ICU burden for a patient who is aware of himself or herself. And for that reason, what do? We have to go to the next slide, and we'd like to tell you about why we have to sedate this patient. So we try to sedate this patient in order to control the patient, like their movements. One, like to prevent extubation. When the patient is extubated, sometimes they get some level of anxiety and those kind of stuff, and they'll try to be pulling the tubes here and there. So when the patient is intubated, we're trying to prevent extubation of the tubing. Also, we're trying to improve the hemodynamics of the patient, and also improve oxygen consumption. Because when the patient is lying very quietly, he or she is not using a lot of energy to be using so much oxygen. And also we sedate in order for the patient to be more comfortable. And this normally, like I said, decreases anxiety or even eliminate it totally. And also the patient can also go through some painful procedures, without a flick of a pain or anything like that. Also, when the patient is sedated, the nurses are more comfortable to deal with the patient. So go to the next slide. All right, our learning objective today will be, after this presentation, the pharmacist should be able to identify the basic characteristics of dexmedetomidine, distinguish between dexmedetomidine and the standard sedatives, measure the efficacies of dexmedetomidine and midazolam, assess the drawbacks of using dexmedetomidine in the ICU patient, and recommend dex over midazolam for decreased delirium and increased analgesia. Next slide. So we're going to have to go a little bit back to our classrooms and talk a little bit about the pharmacology of dexmedetomidine. And as you can see, it is a popular guy over there, Prexides, which we've been handling all the time for our patients in the ICU and elsewhere. And the characteristic that I started with, that dexmedetomidine is an S enantiomer of the medetomidine itself. Its molecular weight is 236.7, and the empirical formula is C13H16N2 hydrochloride. I just brought in there, just to give you a gist of what the chemical structure looks like. And I'll go on to the next slide. Mechanism of action of dexmedetomidine is relatively alpha-2 adrenergic agonist, and this is based on how you use it. Like the alpha-2 adrenergic agonist is when the dose is like between 10 and 300 micrograms per kilo. And at the same time, you're gonna have to run it at a slow rate. When you change the rate of infusion to high or rapid and increase the dose to about 1,000 micrograms per kilo, you're gonna see both alpha 1 and alpha 2 activities going on with dexmedetomidine. But for our concern, you know, like in the hospital, we only use what do you call it, 10 to 300 micrograms per kilo, and we make sure that we run it at very slow rate in order to get the selective alpha 2 adrenergic agonist. Next slide, please. Okay, so still talking about the pharmacology of dexmedetomidine. How do we get the anesthetic effect? The anesthetic effect is by the stimulation of the central post-synaptic or presynaptic alpha 2A receptors in the locus coeruleus of the brain. And also, we can also get an analgesic effect. And this analgesic effect can be seen in the spinal or supraspinal mediated mechanism or in the peripheral by anti-nociception via the enkephalin-like substances that are, what do you call it, dexmedetomidine kind of act like. Next slide. Going to the pharmacodynamics. When dexmedetomidine is injected, we see some sort of respiratory depression is decreased at the range of this recommended dose. And this recommended dose is what is approved by FDA. But later on, we're going to see that there was a study that was being done, you know, just to go above this dose and see the safety and efficacy of the drug. The pharmacokinetics of dexmedetomidine is that the distribution half-life is about 6 minutes. So that means when you infuse it, it rapidly gets distributed, and you're going to see the effect within about 6 minutes. Elimination half-life is about 2 hours, and steady-state volume of distribution is about 118 liters, and the total body clearance is about 39 liters per hour. Protein binding is very, very sufficient, you know, which is like 94% right there. Next slide, please. Metabolism is mainly metabolized by the liver, and the action is glucuronidation and the cytochrome P450 mediated actions. Excretion is mainly renal, and the renal excretion is like about 95%, and the fecal excretion is 4%. Next slide, please. Dosing depends on the procedure. The dosing of dexmedetomidine depends on the procedure. Adjunct to general anesthesia, you know, we can use it as an adjunct to general anesthesia, and then dosing is 0.5 to 1.5 micrograms per kilo IM, and it's given like over like 60 minutes before surgery, and you can also use 0.5 to 0.06 micrograms. I think there's a typo right there. Yeah, IV 0.5 to I think 0.6. Yeah, so delete this 0, please. So it should be 0.5 to 0.6 micrograms per kilo IV, and that is also can be used for the adjunct as a general anesthesia. Procedural sedation, like when we're trying to do like cataract surgery, we normally use 1 microgram per kilo IV over 10 minutes. Next slide. And what we normally use it for in this hospital is sedation for intubated or mechanically ventilated ICU patients. And then the loading dose is 1 micrograms per kilo IV over 10 minutes. That is a loading dose. Then the maintenance dose can be maintained between 0.2 and 0.7 micrograms per kg per hour for a maximum of 24 hours. And this is just what is recommended by FDA right now. But then, like I said, there's a test that, a study that we're gonna be going through, that they did a study to find out that we can use it for more than 24 hours, as we've been doing it in our hospital right now. And there's a note here telling us that when the patient is being converted from like an alternative sedative, like let's say midazolam or propofol, we don't really need the loading dose, this guy, to be administered. You can just go straight to the maintenance dose. Next slide. Dosage adjustment. Renal, when a patient has a renal impairment, it's been found out that Cmax, Tmax, area under the curve, half-life, clearance, and steady-state volume of distribution, they are all not affected. So in this way, when the patient has a renal impairment, there's no need to renally adjust the patient in the dosage. But according to studies, caution should be made to take care of the metabolites that may be accumulating. So if this patient is being on dexmedetomidine for a while and we see some sort of reaction going on, we should be suspicious of the metabolites. And hepatic impairment, yeah, we have to consider adjustment in both the loading and maintenance doses. We found out that with a reduced hepatic clearance, when hepatic impairment is around mild, like a mild hepatic impairment, there's about 74% reduction in the clearance, no, 74% reduction in the clearance. When the moderate is about 64%, and when it's very severe, it's about 53%. Next slide. Now we go on to the indications, and like I said, this drug is it's been approved by FDA, and the approval was done since 1991. And the approval is for sedation in ICU patients, initially intubated and mechanically ventilated. For sedation in non-intubated patients for short procedures, and other uses which is not FDA approved, could be cough induced by fentanyl, fentanyl-induced cough, shivering from anesthesia, like especially in the OR, and post-surgical anesthesia. Next slide. Go on to the adverse effects, and we see that we see hypertension and hypertension coming at the same time. Confusing, right? All right. When you initially give dexmedetomidine, the initial pharmacokinetic paradigm is like it raises the blood pressure just a little bit up, and so it's normally seen with the initial bolus, like when you're giving the loading dose, you see hypertension going on, but then in the course of an infusion, IV continuous infusion, you're going to see hypertension coming on. And the other adverse effects are nausea, bradycardia, pyrexia, agitation, and hypokalemia. Somewhere they say something about that, let me see, the peripheral vascular resistance is also normally increased. So, and also systemic vascular resistance is also increased, but I didn't include it here. But mainly, when dexmedetomidine is normally given, we have to be watching the hypertension, especially hypertension and hypertension between the two of them, and bradycardia. Next slide, please. Now, if dexmedetomidine is coming on the market to join the big guys, and the big guns are what, the benzodiazepines, and just want to talk briefly about the benzodiazepines. And then we know that benzodiazepines are gamma aminobutyric acid, which is a GABA receptor agonist. And most of what we use in our ICU right now are like lorazepam and midazolam. And this is accepted as the standard sedatives in the ICU. It's been used for decades, and side effect profile requires close monitoring though. Long-term use could be hazardous, and most of the side effects or the hazardous part of it would be the delirium and respiratory depression. Next slide, please. Okay, Now, so if we want our friend dexmedetomidine to join these big guys, benzodiazepines, I think we have to conduct what do you call experiments, right? Or studies. And studies were done. Most studies, popular studies that have been done are the mains. The mains compared lorazepam with dexmedetomidine, and they found out that dexmedetomidine was favored. The MIDEX trial was also performed, and that was midazolam versus dexmedetomidine. And they found out that dexmedetomidine was not inferior to midazolam. That means they were running neck and neck. The PRODEX trial was done with propofol versus dexmedetomidine, and that one too was found not to be inferior to propofol. That means they were also running neck and neck. So in other words, this dexmedetomidine is very, very potent. But there was one study that I just want to discuss with you tonight, and this is the SETCOM trial that was performed somewhere around 2005. Okay, so the SETCOM trial was done to check the safety and efficacy of dexmedetomidine when it was compared with midazolam. The study design was very strong, and it was like prospective, double-blind, multi-center, international, randomized trial. Study conducted was between March 2005 and 2007. This was way after dexmedetomidine was approved by FDA. The subjects were randomized from 68 centers in 5 countries. Next slide. And the method of the study was approved by the Institutional Review Board. Informed consent was signed by a patient or legal representative. Data were collected, data were collected and analyzed by a third party though. So we go on to the next slide. Still with a method of study. The inclusion criteria for this study was age, should be 18 years or older, intubated and mechanically ventilated for at least 96 hours, shouldn't be less than 96. Anticipated ventilation and sedation should be more or equal to 3 days. Next slide. The exclusion criteria was when you're diagnosed with trauma or burns, you'll be excluded. Patient shouldn't be on dialysis. Neuromuscular blockade, if you're on neuromuscular blockade, you'll be excluded, except if it was only used for intubation. And if the patient was on epidural or spinal analgesia, they were all excluded. Continue with the exclusion criteria. If you're pregnant, heart rate is less than 50 beats per minute, the serious CNS pathology like acute stroke, uncontrolled seizure, and acute, hepatitis or severe liver disease with a type of class of C, you were all excluded from this study. Next slide, please. The randomization was done in this way. Study personnel and the patients were blinded except for the pharmacist. Randomization ratio was performed in such a way that there was a 2-to-1 ratio of dexmedetomidine versus midazolam. They used interactive voice response system and computer-generated schedule to select these patients. Baseline demographics, like sedatives and analgesics, were obtained at the enrollment. This slide. The intervention, what did we do to the study subjects? The study drug was administered within 96 hours of the intubation. Sedatives discontinued before the start of the study. But I didn't see any kind of like washout period that were allowed. But they just stopped any sedative that the patient was on, and then used the dexmedetomidine. All right. The target Richmond agitation sedation scale, which is RASS, was set to be between -2 to +4. And you know the RASS, this RASS can go all the way from, I think, +4 all the way down to -5. But then they set this study to be between -2 and +1. The loading doses of dexmedetomidine is can see here, it's been increased from the 1 micrograms per kilo per hour that was recommended by FDA. And the midazolam was also set at 0.1 milligrams per kilo per hour instead of the 0.05 milligrams per kilo per hour. Next slide. The maintenance dose of dexmedetomidine was also set at 0.8 micrograms per kilo per hour, and the maintenance dose for midazolam was also increased to 0.06 milligrams per kilo per hour. A dosing adjustment was done by the clinical team using the RAS scale. That means if they found out that the patient was not within the RAS score, they either increases or decreases the dose of either of these two drugs, the midazolam or the dexmedetomidine. Next slide. We still continue with intervention. I mean, there was an open label midazolam boluses that were given, and this was 0.01 to 0.05 milligram per kilo every 10 minutes or 10 to 15 minutes intervals. And this open label is like when the patient doesn't achieve his or her RAS and keeps on like waking up and stuff, and that means this open label midazolam was given just in order to protect the patient from coming back, awakening or something like that, yeah. And let's see, the RAS assessment performed at least every 4 hours. They did a RAS assessment every 4 hours. Fentanyl was also given as an analgesia, and it was given like 15 minutes as needed. And then how do you determine somebody who's sleeping with analgesia? I think they use processes like CPOT. We're going to go into that a little bit, or maybe later on I'll give you some vibes on that one later. But they use that one to check the analgesia because even if you're sleeping, you still might be in pain. Okay, next slide. Okay, now we go on to Haldol. If the patient becomes agitated during the study, I think Haldol dose of 1 to 5 milligrams was used, and this could be repeated from every 10 to 20 minutes. The study drug was stopped at extubation as required for midazolam. Let's say that the patient was extubated and is free now to breathe on his own or her own, the study drug will be stopped, which is the dexmedetomidine will be stopped. And if they find out that midazolam has to be stopped too for the patient to be extubated, yeah, the study drug was also stopped. And another requirement was that after 30 days, that's the maximum that they did a study for. So after maximum of 30 days, and also if in the best interest of the patient, the clinician determined that the patient should be extubated or the drug should be stopped, the investigator will stop administering the study drugs. Next slide. Now we come on to the outcome measures. The outcome measures, the primary outcome was, define the percentage of patients that will fall within the RAS of -2 to +1. That means they're comfortably sleeping. And patient within RASS range was asked to perform 4 tasks. And one of them is like open eyes to voice command, track investigator, eyes, squeeze hands, stick your tongue out. And if, on the next slide, if the patient was able to do at least 3 of these 4 tasks, then that means the drug is not really working for that patient, or the patient will be considered awake. And they're going to have to either increase the infusion rate or basically decrease it. Okay, additional drug was added or drug held in order to get the patient, like I was saying before, into the RAS range of the -2 and then +1 during the arousal measurements. And the arousal measurements is like, even though you're going to be sleeping in the ICU, sometimes you're going to be aroused, you're going to be awake, then we ask certain questions by the nurse here and there, just to measure and also decrease the delirium level of what do you call it, the delirium side effects of the drug that's being administered. Next slide. The secondary outcome was basically prevalence and the measure of the episodes of delirium. Delirium was assessed using the confusion assessment method of the ICU, which is normally called a CAM ICU. And there was also a priori outcome, and the duration, this was the duration of mechanical ventilation the patient will be on, and also the length of ICU stay. Next slide. Sample size determination. Considering the safety and the efficacy in prolonged exposure to dexmedetomidine, they came up with some measures of finding the number of patients that will be selected for dexmedetomidine and also midazolam. For efficacy, the mean percentage of time within sedation target was considered to be 85%, and that of midazolam was 77%. To calculate an effective size, an anticipation of about 60% of patients will remain intubated at least 72 hours after randomization. Randomization. Next slide, please. Okay. The sample size for the dexmedetomidine group, at least 150 minimum number of patients was required for a minimum of about 72 hours to permit 10% chance of adverse effect, which is the safety side of the drug occurring, using a 95% confidence interval, give or take of about 5%. Next slide. So this led to the randomization of like about 250, or we're gonna need at least 250 dexmedetomidine subjects and 125 midazolam subjects to perform this study. And if we're able to get this sample size, this will be able to have a 96% power at an alpha of 0.05 to detect 7.4% difference in efficacy. These statistics were all done by those statisticians, and this is their job. They understand it better. Next slide. And also determining the efficacy and the safety, so many tests were also performed. There was the Mann-Whitney test that was used for 95% confidence interval mean difference, delirium-free days, rescue medication doses, and duration of steady drugs. The Wilkerson test was used for the treatment differences. Fisher exact test was used for prevalence of delirium and the use of rescue medication, safety analysis, and incidence of adverse events. The Kaplan-Meier test, or Kaplan-Meier survival analysis, was used to time the extubation and length of ICU stay. The log rank test was used for differences between groups, and the p-value was suggested using the Bonferroni method. These statistical tests were two-sided, and a p-value of less than 0.05 was considered statistically significant. Next slide, please. Patient population breakdown. So after doing all those calculations to get the amount of patients for this study, they were able to come up with 420 patients who received consent, but only 375 were randomized, and 366 received a study drug. That means actually only 366 patients underwent the study. Out of the 366, 244 were dexmedetomidine and 112 were the midazolam. Just to satisfy, you remember before, the 2-to-1 ratio that we talked about. And 9 patients that were lost to follow-up here was due to 3 died and 6 changed clinically. And for that reason, they had to exclude them from the study. The baseline characteristics were similar though, and then the average age was somewhere around like 60. Countries in the study, and then the subjects that were provided by each country also shown here. And USA with 294, Australia 32, Brazil 27, Argentina 11, and then New Zealand 2. Next slide, please. The efficacy analysis. After tests were done, they found out that there was no difference in the primary efficacy outcome. That means dexmedetomidine didn't come short of whatever midazolam was coming up with. So the percent of dexmedetomidine subjects in the RASS range was about 77.3% compared with 75.1% in midazolam subjects. This difference, like the 77.3% minus the 75.1%, this difference of 2.2% falls within this 95% confident interval, which was set at minus 3.2 to the 7.5. Significant differences were seen with occurrence of delirium, and this was seen in about 54% of the DEX patient versus on 76.6% of the midazolam patient. And this 22.6 difference was also within the 95% confidence interval, which was set at 14 to 33. So this is to tell us that the study, which was conducted, showed that it was very powerful to pinpoint dexmedetomidine as being less delirium than midazolam. Next slide, please. So efficacy analysis too on it. So I just wrote a short note here to tell you that time on ventilation was also significantly reduced in the dexmedetomidine group than the midazolam by using the Kaplan-Meier score of 1.9 days less than in the midazolam group. That means these patients on their dexmedetomidine had like 1.9 days less ventilated than the midazolam group. And then the length of ICU stay was also similar, basically for both of them. Next slide, please. Okay, now we come to this analysis of the study, and we know that we saw that the strength of the studies were basically the study design. And the study design, like I told you, was this was what we call it a prospective. Prospective multi-center, double-blind, randomized, controlled trial. And this is a type of study design that allow investigators to make inferences that could be translated into practice. Statistical analysis, also using popular statistical tests that we went through, was also very strong. And also, at the end of the day, the MIDEX and then the PRODEX trials were also able to support the findings of this SETCOM trial. Next slide, please. Weaknesses of the study was that the investigators targeted patients that were treated with a steady drug rather than an intent to treat sample of subjects. So it's like we have the patients that are supposed to be sedated, and so that's what we're treating them for. And so that's why they came up with the targeted patients here that have to use the drug. So they were using the drug not on somebody else that didn't really need the drug, but only the patients that were targeted to be treated. And most of the centers were also too small, and that could also, the population, subject population was very, very small, and that could create the likelihood of selection bias. Next slide, please. So, at the end of all these studies, we could see that the advantages of dexmedetomidine with other studies combined with the SETCOM and that we just went through, that it may prevent harm from adrenergic overstimulation, especially like, let's say when you're using Clonidine. Non-opioid adjunct for pain, we could see that dexmedetomidine could be used as a non-adjunct for pain relief. And during the study, I think most other studies, they were able to find out that dexmedetomidine, morphine, they didn't use that many morphine or that much morphine for what do you call it, pain relieving for the patient. And also, dexmedetomidine was associated with less delirium, and in comparison, some studies found out that dexmedetomidine was only 8%, propofol 50, and midazolam was also 50% occurrence of delirium. And dexmedetomidine could also be used as a detox of sedatives, especially post-op, like right from the OR, and you were on, let's say, what do you call it, anesthetics or sedatives. This could Dex could also be used as an off, what do you call it, like something for like a withdrawal, to treat the withdrawal symptoms of these sedatives. They found out that there was no effect in intracranial pressure and intraocular pressure, so which was an advantage, when you compare it to these guys and this propofol and midazolam. There was decrease in oxygen consumption, like I said before, and there was also decrease in respiratory depression. You can see that very much pronounced in midazolam and possibly propofol. Next slide, please. All right, so I don't want to make it so long. So in summary, the authors were able to stress the need for best sedation practice, which include light to moderate sedation, daily arousal, and assessment. No differences were observed with time spent by the patient in sedation as determined by the RASS range. Dexmedetomidine showed advantages over midazolam with time needed to remove mechanical ventilation and extubation. Next slide. So dexmedetomidine was shown to reduce prevalence of delirium, as we said before. Caution must also be taken to closely monitor bradycardia and hypertension, like I was telling before. Authors suggested that future investigation should focus more on clinical outcomes, including the prevalence of delirium, risk of nosocomial and long-term patient-specific cognitive. Next slide. We see our gentleman here who is nicely sedated, and these are the Richmond agitation sedation scale that I was talking about. If you're not familiar with it, it starts all the way from +4 all the way down to -5, and each one of them has a score to it, and that's how they use to measure the scorings. Next slide. There's another one that's also called a Ramsey sedation scale, but that study didn't really use it. And at the end of this, I would like to end my presentation and invite questions if you guys have any.
I have a question. When would you recommend lorazepam or midazolam over the dexmedetomidine?
Okay. Recommend dexmedetomidine by FDA is approved for only mild to moderate sedation. So recommending lorazepam I wouldn't recommend, because they found out that dexmedetomidine is better than lorazepam. But midazolam, yes. So if you want to throw your patient into, like, let's say, a little bit severe sedation, you can recommend midazolam for over dexmedetomidine. Thank you. Another question?
With regards to the side effect of bradycardia and hypotension, how does the severity compare to the adverse effects with like propofol? Would you recommend a switch from like a propofol to a Precedex?
Exactly.
The patient would be able to handle it, or would you try to switch to another agent?
Yeah, well, like when the bradycardia and hypotension is very, very severe, definitely we're gonna have to switch the patient from dexmedetomidine to a propofol, which doesn't have this kind of reaction, or which can hold very well for those cardiac effects. Thank you.
I'll go again.
Yeah.
So since they kind of had this off-label usage of other kinds of sedation for anxiety and sleep, with no real studies to support dosing, do you think that it's a safe and efficacious use when compared to other things like benzo or a antipsychotic of some sort?
Thank you for that question. That is the reason why, like I said, we had all these tests, like the Midex, products, the mains, and this second trial. There are other so many tests that have been done. So it's like we now have to go outside what FDA has approved, and then even with this test, they considered it as like a stage 4 test because they went beyond what FDA has approved, which after the stage 3 approval, to find out that it could be used for more than 24 hours, as we've been using up there. And coming back to your question, it's like when propofol is being used, right? Let's say propofol is being used. Everybody knows that propofol is being used for many years. Midazolam is being used for many years. So in order for us to go off labeling from what FDA has approved, we're going to have to rely on these studies as intellectuals or as clinicians in order to be able to push like Dex in with the big guns, which is propofol and midazolam. So with the usage, I think more experience comes with the usage than like what do you call it? Getting it approved by the drug company again. You got it? Or I'm not clear.
I think you got it.
Oh, okay, great. But we gain more experience with the usage and then report it, and then people come in. Oh, okay, I saw this and it's true, something like that. Yeah. One last question, easy one. That was hard. Okay.
Do you foresee any future FDA approvals and indications for precedents?
Definitely, because with these many trials coming out, and like I told you, we've been using it, not what FDA has approved anyway, but we've been using it like we know how it's being used for. Yeah, I know that FDA can come up, like I said, the stage 4 trial, with like this, with the second trial. FDA can look at it and say, okay, we're going to change the indication from only 24 hours to, maybe forever. Whilst the patients are being monitored on it. Yeah, thank you. All right, I'd like to end up this presentation. I thank you all for coming, and thank you very much. Blink.